Pain is a complex and pain is a multidimensional experience, and we have to take that into account when we're introducing and making changes in pain management. This is a presentation on how to provide and how to get sustainable changes from pain management. It's a Picture of Pain podcast from DoloTest, and as always you can find us at the DoloTest website at dolotest.com. It is a fact that patients with persistent pain often are going to live with their pain for many years. In some studies, 85% of persistent pain patients were still reporting pain after 12 years. So changes that are sustainable are important and indeed crucial. But more than that, the individual patient must learn to live with their pain and its consequences for their quality of life, and therefore must learn how to handle pain life's ups and downs, must learn to have coping strategies. This requires active participation from both the pain patient and the care provider, and that's one of the main objectives for developing DoloTest, to create a tool to facilitate active participation from the patient and the healthcare professional, and to ease their communication and their common understanding. If you haven't seen the presentation 10 Easy Steps to Patient-Centered Pain Care, it might be a good idea to see it before continuing here. You can find it at the DoloTest website at dolotest.com or as a podcast in Apple's iTunes. We use the term compliance for a patient's adherence to a recommended course of treatment, or about a healthcare professional's adherence to recommended guidelines, but here we use the term for a patient's adherence to treatment. When the patient is doing as told, based on the information given, we talk about high compliance, which is good. When the patient doesn't follow advice and doesn't respond appropriate to given information, we talk about low compliance. Of course, we want high compliance, and therefore we provide information and even more information to nudge the decision in the wanted direction. But far too often compliance is low, and one of the key factors are that we don't take other, but for the patient consciously or unconsciously related aspects into account. We provide or suggest a solution to a problem, but other aspects and problems with powerful influence surround it. We might suggest a patient to quit smoking and provide strong information on why, but the patient can have other interests related to smoking, like calming down, feeling good, feeling relaxed, part of quality of life, etc. And despite the powerful information, the adequate response fails to happen. Acknowledging this problem has led to a wish to get concordance. When talking about concordance, we mean involving the patient in the decision-making to improve patient's compliance with medical advice. By involving the patient in the decision-making, the patient gets higher responsibility and ownership of the recommended treatment, and thereby getting higher adherence to treatment, getting higher compliance. We can say that concordance provides a link between the patient and the healthcare professional. So information is important. But lack of adequate response to information is not necessarily more information, even though there's a tendency for us to think so, both when advising the individual patient and when giving health-related advice to the public. Not responding to provided information called for even more and often louder information, we have a tendency to think. But it might not always be so. If it were, society would not be facing the health problems we have right now. Nevertheless, looking at cardiovascular disease and what have been achieved there in the prophylaxis, we can learn something very important. Reducing cholesterol, reducing blood pressure, reducing blood sugar, all to reduce the risk of cardiovascular events, has been challenging. In prophylaxis, obviously, neither the patient nor the healthcare professional knows who will benefit from the interventions. And often we talk about medication with potential adverse effects or interventions that might be associated with what can be experienced as unpleasant, like exercise, but nevertheless, the success rate for following advice is rather high. And this has partly been done by introducing feedback to the patient. By measuring and let the patient understand the result of cholesterol, of blood pressure, of blood sugar, etc., the patient is provided with understandable feedback, telling the patient that their effort is worth something, the reality is changing, reflected in the change parameters. By that, feedback provides both a reason and a reward for following treatment, and doing so by making an important change from abstraction of the result to achievable goals and knowing when they are reached. DoloTest is providing easy understandable feedback by presenting the response to treatment visually as a DoloTest profile, both regarding pain and other aspects of living with pain by the quality of life. The patient gets important information and feedback regarding response to treatment. This is equal to reduced cholesterol level and thereby reducing the risk for cardiovascular disease. But let's have a look at a case. It's about a 32-year-old woman suffering from persistent pain due to whiplash after a traffic accident some 5 years ago. This has led to headache, and she is now seeking help because she could no longer manage her job at a grocery store, followed by coming home and manage the family. And this is the first DoloTest profile demonstrating universal problems. At that time she was taking over-the-counter medications like NSAID and acetaminophen or paracetamol, but nevertheless experiencing high level of pain. But in fact she had problems on all levels, also by light physical activities like everyday tasks at home, by more strenuous physical activities like walking and exercise, and by doing her job, part of what had led her to seek help that day. She had no energy and complained of being tired always. "I'm yelling at my kids and I'm not a mom doing so," she said. She experienced reduced mood, she felt socially isolated, including her own family, and she had problems sleeping. Indeed, she had a low quality of life. Asked where to start and what she wanted to achieve by the treatment, the goals: she wanted to sleep better, to feel less tired, and to be able to manage her family and her job just as she was used to. She was of course examined and there were no new findings and no red flag symptoms. Over-the-counter medication was discontinued gradually and she was put on amitriptyline at night. She started on physical therapy, and due to side effects on the amitriptyline, she was advised to switch to gabapentin, but she was reluctant to do so due to the just experienced side effect and when informed about the possible side effects on gabapentin. But a compromise was made. She agreed to make a trial period and then evaluate. Coming back, she told that she felt somehow better, at least she slept better at night. But when seeing the DoloTest profiles, and that's the black one, she realized that the treatment, both medical and non-medical, had improved her condition. And she continued, and supported by regular feedback by the DoloTest profiles, treatment was adjusted and she was able to return to her normal and wanted life, both by the family and by the job. But still experienced some pain, but was able to cope with it. So to summarize, involve the patient directly in the goals and the decisions. Do not just advise. Provide feedback the patient can understand. Establish a test period if needed and evaluate. Follow up and show you care. You can learn much more about DoloTest at the DoloTest website at www.dolotest.com, where you can also find out how you can start using it. You can also find the Picture of Pain blog and learn more about the Picture of Pain podcasts. Thank you for stopping by.